Ok, es un gran placer presentar al próximo expositor, el doctor Mark George. Él es un psiquiatra y neurólogo en Charleston, en Carolina del Sur. Ha estado involucrado en investigación con estimulación magnética transcraneal y otros métodos de neuroestimulación desde el año 1990. Es el editor en jefe de la revista Brain Stimulation, que es la revista más importante del mundo en su especialidad. Debido a su extenso trabajo clínico y de investigación, el doctor George es considerado el padre de la estimulación magnética transcraneal en psiquiatría. Y de otros métodos también de neuroestimulación, incluyendo la que hizo referencia hace unos minutos Paul, que es la TDCS, ¿no? La Transcranial Direct Current Stimulation. Un especial agradecimiento al doctor George, que estuvo hasta estuvo viajando por la sierra y selva del Perú por 2 semanas, hace una semana, y se iba a quedar para este simposio, pero tuvo que regresar por razones de trabajo a Charleston y ha venido especialmente por un día, ha venido esta madrugada para participar en este simposio y se regresa esta noche. Así que un reconocimiento especial. I'll translate that for you later because, you know, I'm talking about the fact that you had to go back home and then you came back for the symposium specifically. Okay, so es un gran placer presentar al Dr. Mark George.
Thank you very much, Mike, Dr. Kabar. My Spanish is not very good, so I have no idea what he said about me. I assume that it's pretty good. I'm delighted to be here. This is a great crowd. It's really good to see brain stimulation spreading around the world, and especially good to see it spreading here in Peru and South America. We have really the experts from most of the South American countries here. This is a really exciting time in our field. When Mike asked me to talk, I said, well, what I can try to do is talk about some of the newest research about how to make TMS work better for depression. And so I want to focus this talk, which is very clinical, on whether we can change dosing regimens or extending dose or synchronize TMS with the EEG. This is the town that I'm from, Charleston, which is actually straight up on the same longitude line, just straight north of here. So I'm not jet lagged. It's a beautiful town. You're all welcome. This is the slide that they require in the United States, where you talk about who's funded your work and then whether there are conflicts. Years ago, I decided not to get a patent about using TMS to treat depression, and I've tried to stay kind of financially independent and being able to be a scientist and say whether something works or not, and not have that impact my my checkbook, my finances. And so I really don't own any of the device companies, and because I'm in charge of a VA trial, I can't take any money from anybody who makes anything related to TMS. I do also work as the editor of a journal, Brain Stimulation, which is a really exciting job where I get to see all that's happening around the world in this field. This is the slide that I think is the most important for the whole talk. This is the cartoon of a neuron and how information flows down the nerve, and then we get release of the neurotransmitters in the synaptic cleft that are then reuptaked here. And this is the cartoon that I grew up with. And this is where dopamine works, and Prozac, fluoxetine works. This is where amphetamines work. This is where opiates work. This is a very important system. It's modern psychiatry. It's modern neuropsychopharmacology. However, what we forgot is that the brain is an electrochemical organ, electrochemical. And so what's happening is electricity is coming down this nerve cell, and electricity is what causes the chemical to be released. And all that happens is that the chemical determines whether or not the next neuron will transmit the electrical signal. So in some ways, all of pharmacology is nothing but a modifier of electricity in the brain. We knew that, but we kind of forgot about it because pills work and the synaptic cleft is so important. But when we remember that it's electrochemical and that electricity is actually the currency of the brain. The brain does all of its work, all information, all signals are electrical. Then it makes a lot of sense that when we discover new ways of getting electricity into the brain, that they should have very powerful therapeutic effects. So this is kind of the whole revolution in brain stimulation in one slide. And I've run out of electricity in this. If we have some batteries, that would be great. Oh, no, I didn't have, never mind. I got it to work. Okay, good. So this is a partial list of all the different ways. We have electroconvulsive therapy, TMS, deep brain stimulation, vagus nerve stimulation. These are all FDA approved for some indication. And then down here we have all of these new areas. There's transcranial direct current stimulation you've heard about. Magnetic seizure therapy, where you take a TMS device and on purpose make a seizure happen. There are TENS devices. I don't know if those are sold in this country. Fisher-Wallace, Alpha, STEM. There is transcranial alternating current stimulation. And then actually you can take an ultrasound. So like you use to look in the womb at a baby, and instead of looking with the ultrasound constantly that gives you the picture, if you pulse the ultrasound, that will actually cause neurons to fire. And so people are actually investigating whether you could use pulsed ultrasound as a way to actually stimulate the brain. And that's quite exciting. It works, actually. To cause pulsing, whether it works therapeutically is another question. So how do we move forward? So I did a lot of work over the last 23 years. A lot of people, and not just me, but a lot of people, have figured out a way to make TMS work partially for depression. Dr. Bononi kind of reviewed nicely what we know now, how it works. But how do we move forward? How do we make it better? So I think, candidates or how to make it better would be improving where to stimulate, and I really enjoyed your systematic look at some of the rules. Varying what we do in the brain, and potentially combining brain treatment with brain behavior therapy or talking therapy, or changing the rhythm of stimulation. And I'm going to talk a bit about each of those. So Dr. Bononi went through how TMS works. We can use it either as a research tool, and you saw how to use it to get at GABA measures. I don't know, has anybody ever seen it used to interrupt a process? I'll show you a slide of that in a minute. Or you can use it as treatment. So let's see if I can get this going here.
When a community in New Orleans gets the investment it needs, we know our brains run electrical into that circuitry. Imagine a magnetic. I offered.
So this is an example of a TMS device. We have a partial one in the back, but of those who've never seen it, so this is where the pulse goes over the motor area and causes his thumb to move. You can move it slightly up and then get to the area for the toes. So you can see, you have to use a bigger coil, right? Or you can use higher frequency.
It can even affect someone's speech.
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
And once the pulse is removed,
25, 26,
everything goes back to normal.
29.
I don't know if you could hear me, but I was counting out loud, and then they move the coil slightly over what's called Broca's area, the motor area in the brain that's controlled with speech, and it will temporarily interrupt your ability to talk. It's a very interesting psychological feeling because in your mind, while that's going on, you're counting out perfectly. So I was going 1, 2, 3, but then what comes out of your mouth is mush. It's garbage. And my reaction to that is frustration. And I don't know if you've ever dealt with patients who've had a stroke and who have aphasia, that they are just so frustrated. And now I understand it's because inside their mind, they're speaking perfectly. It's just coming out in a crummy way. But anyway, TMS can be used as an interruption tool like that. So something that can be used, it's powerful. So maybe we should be able to use it to treat depression. And you've heard several good talks today about that. So why did I think we could use it back in 1993? Well, one of the reporters was asking me that earlier. It's not working. Depression is an interesting, it's almost like an infection, right? You become depressed, and if you can get out of the depression, you go back to the way that you were before. So it's not like Alzheimer's disease, it's not like Parkinson's, it's a state that takes over your brain, and if you can get rid of it, you go back to normal. And we have very good evidence that ECT can change that state. And so early when I was doing my work, I had the idea that a form of stimulation can reset the brain out of depression. And so that's really what got us motivated. And we have these ideas of loops, of cortical subthalamic loops. This is an example of what I think is going on in depression. Normally we have our emotional limbic area and our cortical area, and when we get bad news, our cortex comes to the rescue and quiets us down. In health. In depression, that circuit is not working correctly. And if you talk with depressed patients, or if you've ever experienced depression yourself, you realize that your cortex can't do its regulatory job. You can't get perspective on your emotions. You can't get control. So I thought that we could stimulate subconvulsively and get people better. This is the first patient that we did at the NIH back in 1995. This is the Hamilton. These are the days that we treated her. She got better. This was a patient with multiple treatment resistance. And then here's the first, we did her for a whole week with a weekend off, another whole week, and then we phased her out. She has bipolar II depression, which is probably why she responded so quickly with just a week or two of treatment. This is the first crossover study way back in 1997. And then the biggest study to date was an NIH trial that I organized and led called the Optimization of TMS trial. In that study, we did a true double blind where we have a sham condition, and the treater and the patient can't tell what people are getting, so it's truly double blind. And we found in almost 200 subjects that 14% of those getting active treatment reached remission, that is, they had no depressive symptoms, versus sham with 5%. So you have almost a threefold chance of getting remission with the TMS compared to sham. So this was the first really good definitive evidence that TMS works in a industry-independent, highly controlled, randomized controlled trial. So this is great big news, huge news. We've got a new treatment for depression. The bad news is 5%, 14%, those are low numbers. Those are really low numbers. That's not a lot of people. And they have to sit in the chair for this, in this study, 3 weeks. When you do another 3 weeks of open label treatment, the remission rate goes up to 30%, which is good. So about a third of these patients will get remitted with 6 weeks of TMS. And if you look across at the STAR-D study, where you take patients with treatment-resistant depression, they're not getting better, and you give them thyroid or lithium augmentation, their chances of reaching remission are less than what they would get with TMS. So it looks to be as good as a medication augmentation in patients who've tried and failed 2 antidepressants. So it's clinically relevant, but it's still not that good. So now we've had 3 trials. The remission rates are pretty good, safe. In the United States, there are about 700 machines, and I'll talk a bit about durability. The other really good information is that people who use this in clinical practice get results that are better than me. when I use it in my university practice. And that's great. And I think the reason is that we've figured out how to actually train people to do it in a reasonable way. Plus, out in the real world, patients are not quite as complicated or treatment resistant as they are at the university setting. But the good news is in this Carpenter study, they got about a 40% remission rate and a 60% response. So through the years, when people have called me up and said, I want to get TMS for depression, I live far away, I want to come to Charleston, I tell them, no, it's best to sleep in your own bed and stay where you are and get treated in your hometown, and your doctor there will get you well just as good as me, probably even better, because you don't have to travel. So this is pretty good. We have FDA approval now for 4 different devices, and there are lots of other devices being treated, and 70% of Americans, United States citizens who have insurance, can now get TMS paid for through their insurance. So it's starting to become a part of regular clinical practice. That's good. Here's a list of all the different neuronetics machines in America. There are quite a few. It's spreading to other countries, and we have representation here from much of South America. Here's a clinic in Japan, in Tokyo, where they have an entire floor of a high-rise building and 60 machines, 60 machines. And they treat a lot of people every day. So Japan is starting to do TMS in a big way. However, I've been working for 20 years, and we still don't know all the things that Dr. Benoni showed, all the different ways to do it. We don't know which ones of those are the best. We're still not as good as ECT, in my opinion, as a practitioner. ECT has a higher acute rate, it has morbidity, it costs more, it has other side effects. It still takes 20 to 30 sessions. That's a lot of time coming in to see a doctor. So how do we move into the future? So one idea is, can we do more treatments in a day? So I chose the 1 treatment a day paradigm out of thin air. I said I have to do a study. How frequently should we treat them? And so I called up somebody who does ECT research, and I said, how often do you do ECT? And they say 3 times a week. And I say, why 3 times a week? And they say, well, if we do it every day, people get delirious. We have to give their brain a day off, plus their IVs. They just need a day off. And I said, if you had a safe treatment, would you do it every day? And they said, sure. And so we did TMS every day. But there's no good reason why we can't do it 2 or 3 times a day. And a lot of times people live far away from a doctor. And so coming each day, a long travel, it just doesn't work. So this study out of Atlanta, they took 14 treatment-resistant patients, and they gave them 15 sessions over 2 days. So a lot of treatments, about 15,000 total pulses, and they found that people got better faster, very quick responses to the Hamilton. It was an open-label study. And so we built on this one with an anti-suicide study. And the idea here is there anything that's special about having a single treatment a day? For those who make it, can you use a microwave? Can you make things go faster or not? And is the off time needed? And so in this study, we took patients who were admitted to the hospital for suicidality. We gave them 3 treatments a day for 3 days. So they got 9 treatments in 3 days. They got 18,000 stimuli a day and 54,000 total. And what we found was, this is the Beck suicide scale, and in those patients who got active TMS, many of them were almost immediately unsuicidal. Several of them would have left the hospital if they weren't a part of the study. Over 3 days, the active and the sham became normalized, and that's why we do put patients into the hospital. Being in the hospital, with the support of the hospital, suicidality goes down. But what I think is very interesting is this separation after the first day with the real TMS. A group in Korea has done this study, which is not yet published, but they did essentially the same thing. They took patients and gave them 15 sessions in 3 days, or they gave them the normal daily treatments, and then looked after 3 weeks, and the two groups were exactly the same. So you can deliver the same amount of stimuli, very short, and get the same effect. So you can bake the cake faster, and I think that gives us a lot of flexibility in how we might want to use it clinically. And the group who got the accelerated group got a more rapid response. So that's good. You can get people faster, quicker. Maybe in the discussion we can talk about whether some of the clinicians in the audience have used these kind of packets of stimulation. We use them in Charleston a lot now. So, what are our conclusions about the dosing path? In my opinion, there's nothing sacred about one treatment session per weekday. There's no reason why you have to have a sleep every night. We can give a lot more in a day and get the same effects. It appears as if there's a total dose effect, the number of pulses, and so we can experiment with novel delivery patterns. And that works better clinically. And the minimum amount of off time and the maximum number per day, we still haven't fully established. What we do if we're giving multiple treatments in a day is we'll give a session that lasts about 30 minutes. We'll make the patient get up, walk around, give them a break of about 30 minutes, go use the restroom, and then come back. So we require about a 30-minute break between sessions. But there's no good reason why we do that. It's really for patient comfort. It's just kind of getting around. We heard from Dr. Corcoran about where to put the coil, and it's very frustrating when you're treating a patient. They've been in the chair for 4 weeks, and as you've seen, about a third of patients will not get better, and it's very frustrating when they don't. And for me, there's always the nagging question, are we just missing the right spot for that patient? If we just moved it slightly, what is the right spot for that person? If we knew the right spot, could we make it work in 100% of patients? Well, we tried initially this 5-centimeter rule, which is not a good rule because people with large heads, it's too far back. This is the F3 location, and then there's some other areas. The only really good study, there are 2 studies in this area, this was by my friend Dave Avery, and he put a vitamin E capsule on the head where he treated people in a trial and had a scan, and then we went back and looked, and in blue are the locations for the people who did not get better, and in yellow are the locations for the people who did get better. And you can notice that there's a trend towards farther forward and farther lateral in terms of getting better from the 5-centimeter rule. And so that's why we use the F3, and it's interesting that your neuroradiologist in Mayo was pointing forward and down over here, right? Yeah, so it may be that we could slightly position where we go and get even better results. Could you, can I take you and put you in the scanner and somehow determine for you your best spot? How would I do that? Anatomy varies. Some of us have 3 frontal gyri, some of us have 2. So anatomy is not a good way to do it. We could have you do something in the scanner, a functional. I could make you terribly sad, or I could show you distressing pictures and say, try to use your cortex to control your emotions. So I could activate a circuit. But the problem is that varies. Those kinds of things vary across the prefrontal cortex. Here's an example where Colleen Hanlon in our group took patients who smoke, and we put them in the scanner, and we show them cues of smokers, or control cues, and then we look at their brains when they're seeing these versus those. And what we find for the group is that when people are craving smoking, we get a beautiful activation of this area called the nucleus accumbens, this frontal part of the brain. And so this group average would say, oh, we should just stimulate right there and we should be able to treat smoking, right? But if you solve it for every individual, and that's what these red spots are, each person and where their brain is, it becomes much more highly varied. And in fact, if you were to put a single coil, you'd easily miss a third or two-thirds of the population. So it's really hard to do individual dosing for something as complex as a cortical, subcortical regulatory circuit, is the point. We have technology to where we could actually stimulate multiple places in the brain. This is a new coil from BrainSway where they have multiple different coils in a cap. And so you could stimulate one spot high frequency, another spot low frequency. You could do them simultaneously. You could jitter them. The technology is available for us to do remarkable things with TMS. We just don't know from a neuroscience standpoint where to go or whether to drive it up or down, right? And there are lots of different ways to make coils. This is a nice study where all the different kinds of TMS coils that you could ever think of were drawn and then measured in kind of a simple model. So how do we move forward? Are we missing the target in the non-remitters? One group has said you can do a thing called resting state functional connectivity. So if I put you in the scanner and instead of having you do a task, I just say, let your brain go wherever it goes. And what would you do? You would think about what you have to buy at the grocery store on the way home. You'd think about, well, you know, whatever you think about. You just let your brain go. And if we look at the brain activity, we can do what's called a resting state connectivity. Interestingly, the brain, parts of the brain work in concert with other parts. And one group, particularly the group in Boston, has said, well, maybe we could use that to find the target. So it's not really a specific task. And the first author is Fox. And what they've found, is that if you look at this resting state functional connectivity, you can find some cortical targets that do best at actually connecting with the subgenual cingulate, which is an area that many people think we need to turn down. And so at a group level, he can find the best spot, which is actually very close to where we've been stimulating. If you try to do this for an individual, however, it falls apart for reasons that I'm not sure. But this group has tried to do this individually, and it doesn't work at all. So it's a good idea, but not one that we can do at the moment. What about relapse and extended dosing? It's not well studied. We know that after electroconvulsive therapy, over half of our patients are going to be ill again. That's the real problem with ECT. It works really well in a lot of people. It can get them out of the crisis, but 6 months later, over half of them are going to be ill again. That's terrible. It's not much better with medications. If you take people who've tried and failed 2 or 3 different antidepressants and they find the one that gets them better, and then you look a year later, it's still less than 20% that they've maintained remission. So we as a field don't do a very good job at all of keeping people undepressed if they're in the treatment-resistant group. What about with TMS? Well, there have been some studies, most of them not very good. The only randomized trial that I know of is about to appear in that wonderful journal, Brain Stimulation, where we took medication-free, treatment-resistant patients and took those who had gotten better with TMS, and then we randomized them to either one TMS treatment a month, regardless of how they're doing, or just a wait and see. We'll talk with them once a month. Both groups, if they started to fall back into a depression, we would retreat. But the question is, does one treatment a month keep you well longer? Anybody want to know the answer? Anybody know? Anyone want to bet? Oh. Okay, so it was 6 sites. In the active open, to get into the trial, we just treated everybody for 6 weeks. We got a 73% acute response rate. That's pretty good. So, you know, in the part trying to get into the trial, just somebody was talking about the variability across different trials. This one was almost a home run, 73%, almost remission. So half the group was treated once a month, the other half just monitored. Everybody got a repeat treatment if they relapsed. So here's the curve. This is the probability of needing retreatment in the people who got scheduled treatments in blue, or those who were just watched and not treated. And you can see that mathematically, the group that got one treatment a month took, they were more likely to stay well longer. So giving somebody one treatment a month kept them well longer than not doing that. It wasn't a very big effect, but it's actually in the direction where you'd want to go. And I think one treatment a month may be an underdose. We just pulled that out of thin air. And it may be that you need once every 2 weeks, or you may need something more than that. But the idea here is that there is a difference and that you can use TMS to get people, to keep people well. These are patients who are off of all antidepressants as well. So these are patients who are treatment resistant, got better, and then this is for a whole year of no antidepressants. So you can do that. So it's possible to maintain patients with just TMS. The other thing is that once a TMS responder, they're always a TMS responder. So there was a 78% chance of re-response. So if you got better with TMS initially, and then you were okay, and then you got ill again, and we give you TMS a second time, your chances of re-responding are very, very high. And usually the number of treatments that you need to get better is about half what it took in the first course, which is also very interesting. So I'm about to finish up now with other ways of trying to make TMS better. So everybody know the work of Hebb, Don Hebb, a neuroscientist, psychologist. He's famous for the saying, nerve cells that fire together, wire together. What that means is that an active circuit is more likely to be changeable. And so if I want to change behavior in a circuit, I make that circuit active. So if I wanted to change your ability to recover from a stroke, I make that circuit active. We do physical therapy in that circuit. And that while that's active, you can intervene in the circuit and get bigger results than if you just stimulated without movement. So Hebb says that there's activity dependence, and that should matter. And I think that's true. And the other thing about how to intelligently move forward is to talk to the brain in its own language using rhythms, and one of those is theta burst. We heard about theta burst earlier. It's patterned. It's how the brain actually talks. So if you stick a wire into the hippocampus and you listen to what the brain is saying, you'll hear theta burst, brr, 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 which is kind of interesting. That's the brain's own language. And so John Rothwell and others said, well, maybe we should talk back to the brain in the language of the brain. And so we should use theta burst. And it actually is a much more potent way of actually causing change in the brain. So can you use theta burst? It's being done in clinical trials, and maybe you'll give us some insight about what you've learned in Brazil with theta burst. We're just starting to try it in depression work. Okay, what about rhythm? This is my last bit. So rhythm, I think, matters. This is a very interesting study by a genius named Flavio Froelich, who worked with David McCormick at Yale. And what Froelich emphasized in this study is this concept of what's called ephaptic coupling. So we know that when the brain is working, it sends electrical signals, and that whenever there's electrical signals, there's also a magnetic field. We can put wires on the surface of the brain, and we can listen to the electrical signal. That's what an EEG is, an electroencephalogram, right? We're just listening to the electrical signals in the brain. We can do the same thing with magnetoencephalography, MEG, where we're listening to the magnetic fields produced by that same electrical activity, right? So there's both electricity coming out of the brain, magnetic fields coming out of the brain. What Froelich and ephaptic coupling says is that if you have a whole bunch of nerve cells and they're firing, that they create their own magnetic field, and that magnetic field that they create influences their ability to fire. So there's some endogenous the magnetic fields of the brain actually act back on synchronization of the brain. And the idea there is that you may be able to make big changes in the brain with very small effects if they're precisely timed. So if you, by not actually acting on the nerves themselves, but just by acting on the magnetic field that's being created. Very clever, but he's shown in a series of studies in petri dishes and then in small animals that you can do this very precisely timed stimulation that's weak. It's not enough to move your thumb like with TMS, but if it's precisely timed, it can cause the system to change. Very interesting. And there's this thing called Arnold's tongue, this looks like a tongue, where if you're trying to stimulate at a frequency, if you have a very powerful signal, you can be far off from the actual frequency and cause it to entrain. Whereas if you have a weak field, you have to be almost right on the signal. The way I think about this is when my children were young and they were in a swing, and I was trying to push them to get them to go higher, and they would yell at me if I didn't do it right. If I did it right, they would be happy. And I learned to precisely time my push. And I could actually give a very small push if I was precisely timed. If I got distracted, and I'd have to give a big push, and it might be herky-jerky kind of. So that's what Arnold's tongue is saying, is that if you want to entrain a system, that a weak signal can do it if it's precise otherwise. So I think with TMS, we're up here, and we might be able to change a system pretty far away, whereas with very weak fields, we might have to be right on the frequency. So what does this have to do clinically? Well, there's this machine. Has anybody seen this machine? It's called the Nest device. The company is called NeoSync. So they have a device, and these are very small magnets, 3 of them, and they're not electromagnets, they're actually static magnets. They're round. And a magnet always has a north pole and a south pole, right? And you know, you can put them and they can either repel each other or they can come together. So if you spin a magnet, the brain underneath it will see magnetic field, no magnetic field. Magnetic field, no magnetic field, as it spins, right? So these magnets spin in a coordinated fashion. And what's the frequency that you would want? Well, there's a thing called the alpha frequency that we all have. That's a tension, and it varies across individuals. Yours might be 8, and yours might be 12, but it's like a fingerprint. It stays the same through your life. So the idea is you'd want to push the swing at 8 for you and 12 for you. If I pushed you at 8, you probably wouldn't get an effect. So their trial is actually to stimulate with this weak device and see if they can get people better. The beauty of this is you could send this home. You could put this in a school. There's no risk of seizure. It's very inexpensive. This could be treated in a doctor's office or at home, actually. So this study was published last summer in that great journal. And here are the results. These are changes in Hamilton score from baseline over weeks. And I've chosen to break it out here in 2 different ways. So there are people who were treatment resistant, that is, they'd failed 2 trials, and then there were some people who had never failed any antidepressant, right? Most of the studies that we've seen in depression have always been in the treatment resistant group. And everybody asks me, well, why are you doing it there? Well, here's the reason. The reason is, look at what you get with the treatment naive sham. They get a great response. If you take people who are first episode depression who are treatment naive, they get better with everything. You shake their hand, you say hi, you're great. You can get a 60% response rate in new onset depression. So you get a very high sham rate. And so for the naive group, there was really no difference between sham and the real thing. But if you look at the treatment-resistant group, so here's the real treatment-resistant group, and then here's the treatment-resistant sham group, once you've failed 2 medications, you don't respond to sham. And so here, you can see it's statistically significantly different. So their device works scientifically in the treatment resistant group, but you can see it also works in the naive group. And I think the same is true of conventional TMS. It works just as well in the naive group. It's just very hard in a study to show it because the sham rate is so high. Anyway, these results showing a statistically significant difference in the treatment-resistant group are good, but the FDA has said they're not good enough, and they want another trial, and so this company is doing another trial before this device will get FDA approval. But if it does get approval, and I think it probably will in the next year or two, it's a game changer because this device can go home with patients, and it will change what we do and how we do it, I think. So there's no approval. Oh, interestingly, they threw 12 subjects out who weren't stimulated at the right range. And guess what? None of those people got any better. So it may be that you really do have to hit the swing precisely. They didn't do a formal study. I think a really good study would be to treat at the right frequency and then the incorrect one. That would be scientifically good. The company chose not to do that. In my opinion, these effects appear weaker than what we get with real TMS and much less than with real ECT. But it's so easy and inexpensive and could go home. So it might be something that we'd use more in first-line depression or maybe just after one medication failure. So I do scanning, and you can do all of what we've been talking about inside a scanner, including a coil. And what we're doing now is we can actually get EEG out of the scanner as well. And we're doing a series of tests where we stimulate when the brain is cycling up or when it's cycling down. So does it matter, say during alpha, whether we stimulate when the brain is cycling up or cycling down? If you listen to a car out in traffic, you can hear the carburetor going up and down, up and down. So the brain does the same thing, oscillating. So should we use TMS where we synchronize it with what the brain's actually doing? Will we get a bigger clinical effect if we synchronized it? If I have a heart attack on the way to the airport, in any airport, if you run over to the wall and you get a cardiac defibrillator and you bring it over and you put it on my chest, what happens? Anybody know? It won't stimulate until it reads my rhythm, right? It has to know what the rhythm is of my heart before it will do it, and then it will give it synchronized. So the entire field of cardiology has realized that rhythm matters and that stimulating, knowing what the rhythm is and in synchrony with the rhythm gives you much better effects. And I think in brain stimulation, we have just ignored this idea of rhythm up until now. And I think there's a lot of potential clinical science where we actually begin to synchronize what we do. So I think we can get better by changing dosing patterns, understanding rhythm. I haven't had a chance to talk about combining TMS with behavior, but that's so important. What people do in the chair, do we give them supportive therapy? Do we actually expose them to trauma? I mean, those are really important things, and Heb would say it really matters. The reason I'm here is I think we need an international community of both basic and clinical and technical scientists to understand this area, to continue to disrupt, transform, and treat, and I'm glad there's an international community in South America. So, we need to become ever more intelligent. At breakfast we were talking about this man, Sylvanus P. Thompson, in 1910. He had one of the first transcranial magnetic stimulators. You can see the magnets here, right? So he would put his head inside this, and it would go off, and he would see a flash of light. It's been over 100 years since Sylvanus. People say that I look like Sylvanus. But if he were here today, he would say, my goodness, you've made so much progress in 100 years, but that there's still a lot more work to be done. So thank you very much. Questions or no? Any questions? No? Okay.
Muchas gracias, Dr. George. Thanks a lot, Mark. No questions right now, but I'm sure we'll keep picking your brain until you go to the airport, so don't worry about it. We'll,